Hey Cam followers, thank you so much for joining us. I'm afraid there's a little bit of an echo on my end just because I'm still at work and doing an impromptu studio in a consult room. The lovely Dr. James is joining us again, but before I introduce him any further, I would like to advertise the fact that we have a fantastic course free of charge in the CAM Education Centre that we would really encourage you guys to go and look at. The lovely Gemma Hodson created this for us. It's fantastic. And what it is supposed to do is not only help canine professionals, be you a dog walker, a behaviourist, a dog groomer, but it's also there for you to help your clients. So if you have a client that isn't quite sure that their dog really is in pain, they're waiting for the limp, they're waiting for the yelp, and they don't really believe you that a behavior change, for example, could indicate pain, then this is the course for you, because you can send them to this course, they can learn remotely, and they can come back to you going, I get it. Thank you so much. So you'll find this at cameducation.co.uk. So cameducation.co.uk. It's free of charge. Please go and use it. Right, back to James, who's way excited. James, tell us a bit about yourself.
Yes, so I have been a vet for 20-something years. Always had a keen interest in managing pain in dogs and cats, and also undertook a master's and PhD in that subject. So now I see quite a few complicated pain cases and kind of enjoy working with them and trying to help them.
Yeah, and I think we just had a little debrief before we went live. Something that really caught me with what we're going to talk about is that you need onboard owners, because it can be a pretty arduous journey.
Yeah.
So what James is going to do is he's going to talk through a case that he's had recently. And what I'm hoping everybody will take home from this is that there's a lot of options out there. So don't get disheartened if the first one doesn't work. You need a good rapport with your vet. So really work on your side of the table as well, building up a trust relationship with your vet, and understand they don't have a crystal ball, that sometimes things can be tried with the best intention, but it doesn't actually get the answer that you want. So James, I'm going to butt in every now and then. We're going to talk for 30 minutes.
Yeah.
Tell us about the case.
Yeah, sure. So this was a lovely case we saw recently. He was called Bryn. He is called Bryn, 10-year-old collie, best breed, obviously. Paul Bryn had been suffering with osteoarthritis of his shoulder for several years, and he'd had radiographs probably 3 or 4 years before I met him, which showed a unilateral shoulder arthritis. So one shoulder joint was badly affected with arthritis. And he'd been managed for, some time with non-steroidal drugs and responded pretty favorably to those. But as time had gone on, they seemed to be less beneficial for him, and the lameness was returning. He was struggling sometimes when he got out of his bed, was maybe less interested in feeding, and the owner was concerned about his quality of life. So they came along to see me.
Tell them how you felt when you arrived, because this makes me giggle, because it's how a lot of vets feel when they see a long history and they go, oh.
Yeah. So, that is a challenge, because his primary vets had done all the right things. They'd tried different non-steroidal treatments. None of those had really had any different impact for him. So your heart sinks a little bit because you think this is going to be a difficult case. If it was an easy one, I wouldn't
come to you.
Yeah, exactly. But we were lucky enough that we were in the days that Librela was available for a short period of time. And so he was able to be one of the dogs that tried that. So he had the first injection, and then a second one 4 weeks later.
Mhm.
We were using the Helsinki Chronic Pain Index just to monitor how he was doing, and then some owner-specific outcome measures as well. And unfortunately for Bryn, his scores didn't change from before the first injection to 4 weeks after the second injection. So that 8-week period, we actually kept him on the non-steroidal for that period of time. So there's work which looks at administering Librela and a non-steroidal for 2 weeks in dogs. So beyond that period of time, it's a bit of a risk benefit in terms of using them together, and we don't fully understand what the risks or harms associated with doing that might be. Anecdotally, they seem to be well tolerated, but there is reports from human literature that there can be an interaction between them, and you can get a accelerated arthritis in some.
But it hasn't been shown in dogs, so people do not worry. If you do hear about that, just talk to your vets, because it comes up in Holly's army quite a lot of, oh, I've heard that it's going to make his arthritis worse. Have that conversation, build the trust relationship with your vet, because as James has just said, in dogs, we haven't found the same. Can you just quickly tell them what Librela is?
Yeah.
And can you also very briefly just talk about why you do objective monitoring?
So Librela is a monoclonal antibody, which is designed for use in dogs, and it's targeted against a chemical in the body called nerve growth factor. And in the young animal, in developing animals, nerve growth factor is important in differentiation of nerves and the proper function of tissues. In older animals, its role sort of switches and it becomes more associated with inflammation and pain. So by targeting it in older animals, we hope that we can address some of the sources of pain. In terms of the objective monitoring, we know that vets and owners can perceive improvements where very little improvement is actually present. So if we're using one of these validated scales, and we're asking the same questions at each occasion, it gives us a measure that we can actually use to assess, are we getting better? Are we staying the same? Are we getting worse?
Yeah. And I think people have to remember that quite often it's quite an emotive disease, and your emotions can really interfere with your ability to be objective. And it's probably one of the banes of our life when you say to an owner, so how do you think we've got on? It's 2 weeks, you've been on this new medication, what do you see? And they're like, I don't know.
Yeah.
So they're really good tools, guys. They're free of charge. All they take is some self-motivation to fill them in. And what we would all dream that you would do is, prior to your reassessment with your vet, print one off, fill it in, and go to them saying, here's my score. Do you know, it'd be saving on time. It'd be so much more objective. Your relationship's going to be so much better. You're going to get to the end point, a good optimum management plan quicker. So I'll do some links in the live, or maybe the lovely Ambassador will do that for me. But please objectively monitor. Carry on, James.
So yeah, we've got a less good response to non-steroidals than we had previously. The Librela didn't have much impact. Paracetamol has been tried occasionally and not given us a particularly different outcome. Bryn also had quite a lot of myofascial pain, so pain around his shoulders where he was tense, and a lot in his hip flexors as well. And in lots of arthritic dogs, that seems to be quite a major source of pain, and it's one that I would generally treat with a physical therapy, so an acupuncture or a laser type therapy. Unfortunately, Bryn was so sensitive that he didn't tolerate acupuncture really at all, and even laser I think was uncomfortable for him as well. So he was so sort of stressed by our attempts to do those kind of treatments. I think, we couldn't deliver an effective treatment for him, and it was making him more stressed, so we discontinued those. We also did try a muscle relaxant. So sometimes muscle relaxants can be useful in these kind of muscle tension cases where we think the muscle is causing a lot of pain.
That's very clinician dependent, isn't it? There's some people that really jump to them quite quickly, and there's other people that just don't go near them at all. So don't be surprised if your clinician is a little bit, what is that? Do mention it, guys, but just have a trust relationship with your vet so that you can have an open conversation.
So that's very much the difficulty. So we've got 3 licensed treatment forms for dog, or main licensed treatment forms. So we've got the non-steroidals, we've got the Librela, and we've got tramadol licensed as long-term management of dogs. We've got Cartrophen as well. So you kind of run through the gamut of what has a marketing authorization, and if those aren't working, then you start having to think a little bit outside the box. And unfortunately, for those kind of cases, we do have less evidence. So, poor old Bryn. Methocarbamol didn't really help his muscle spasms at all. Amantadine was tried. So obviously, we've got some evidence that amantadine can be helpful.
What kind of time scales were you giving? Because I think another thing people want is for these medications to be a light switch, and you start the medication, and by the end of the week, you know whether it's worked or not. And it's really distressing for owners when you say, "I'll see you in a month. I want to see how it works." And they're like, "But he's limping now."
Yeah, no, that's right. So we were looking at kind of 3 or 4 week intervals between changing a treatment, because you don't want to write off a treatment that might be effective if you haven't seen an instant result. A lot of these things, the pain's taken weeks, months, years to get there. Expecting it to diminish, within a few days is asking quite a lot, I think, especially for these more adjunct drugs that we're using here. So amantadine, no real change. Gabapentin is our other one with weak evidence for management of osteoarthritis pain. No change. So at this point, we had to say, right, we've been through the kind of logical steps that we manage 95% of our osteoarthritis pain cases with, and we're not seeing a response. Are we treating the right thing, or is something else happening? Have we got, a bone tumor developing? Which, would, it was a long time scale, so, hopefully not, but it's a possibility. So we made the decision that we would re-X-ray Bryn. It was 3 or 4 years since the previous X-ray, so it seemed to be...
And just to butt in, I think a lot of people think X-rays will always give you the answer, but again, they don't. So as soon as you said that, I was thinking, could it be a nerve root tumor? Could it be a nerve root signature sign? And they're not going to be visible on an X-ray.
That's right.
And by now, this owner's been going through this for 6 months. Would it be?
Yes. Yeah. Exactly.
That's tough.
Yeah, it's really hard. It's really hard, and it's hard for us as vets as well, because we want to help. And you keep saying, well, okay, well, this is the next step, and obviously you're hoping that that's going to be what cracks it, but no. But no. So Bryn came in for his X-rays. It was very marked arthritis of that shoulder joint. all the other joints appeared normal. We couldn't get kind of pain in the axilla and things like that you would expect with a nerve sheath tumor. So while he was under the anaesthetic for the X-ray, we spoke. Luckily, I work in my day job in a referral hospital, so we've got specialists in surgery, specialists in neurology, and so we spoke to one of the surgeons as well to help with this case. And he felt that trying a steroid injection into the joint would be worthwhile doing. So that gives
which is a common thing with shoulders, isn't it? Because they've got the soft tissue in them, so they, if it was related to the biceps tendon that runs through that joint, then a steroid makes a lot of sense. So yes, totally. God, yeah. But what?
Yeah. So you've got a pretty potent kind of local anti-inflammatory effect then. And potentially if we're putting it straight into the joint, then we might be exposing the whole animal to fewer steroid side effects. Unfortunately, this joint was so severely affected that our poor surgeon, try as he might, couldn't actually introduce a needle into the joint space. And so we weren't able to deliver that steroid medication into the joint. So at that point, we kind of went to plan H, and because Bryn was already in the hospital, we thought, okay, well, let's take this opportunity to actually try an infusion of pain-killing medication. So we used a drug called ketamine and a drug called lidocaine as an infusion overnight with Bryn in the hospital. Kept him on those, monitored him in case of any side effects. And the following morning, he was actually happier to put weight on that front leg. He was a lot more comfortable. And so Bryn was discharged from the hospital. He went home to continue with his non-steroidals that he was already on. But he's actually gone from strength to strength.
Wow.
And has had a prolonged, several months duration improvement, seemingly related to the infusion of those painkillers. So again, though they're not licensed for that use in dogs, so it has to be done on an individual risk-benefit assessment, and there are side effects to be aware of, and involves being in hospital for a time. But certainly for him, they seem to have shown an improvement when nothing else seemed to be helping, and actually a lot of the muscle pain is also reduced. So it's really interesting.
No, that's, and I think as I say, the take homes for all that is James was working with that owner on a monthly to 6 weekly basis with multiple visits, multiple decisions, repeatedly not getting the results. But that owner had that understanding and that trust in you that they were like, okay, we'll try the next thing. And I think another take home, guys, is please don't go to your vets tomorrow and go, right, I want a ketamine and lidocaine CRI now, because there is something called recognised veterinary practice, and we have a procedure to follow, as James was saying, is that medications are licensed for certain situations, and you can't jump from A to X just like that. You do have to go through a process, and it's there for a reason. So please, again, be kind. The idea of tonight is to give you hope that there's further treatments out there, understanding of the veterinary process, and hopefully give you the ability to work better with your vet. I love it. I did a ketamine CRI, one of our staff members' dog the other day, and we're now 3-4 weeks later, and she just texted me today and said, look, I think he's beginning to go downhill again. And so that was hugely beneficial. She saw a much happier dog within a short space of time.
Yeah, that's great.
Do you do them often?
We don't. Sorry?
Do you do them often?
Our signal's a bit bad, sorry. We do them very often perioperatively. I suppose increasingly for chronic cases, yeah. But the difficulty is predicting cases which are going to respond to them, because, you know, a stay in the hospital overnight, and the drugs and the, you know, setting up the infusion and things isn't a cheap undertaking. And, you know, we're at a stage where we really don't have enough evidence to say, well, look, this many dogs that have had the treatment improved. So it is very much a case of, if the vet thinks it's appropriate, then trying it. And if you get a good response, great. But there's probably no way of knowing beforehand whether you will or not.
No, and I think just butting in from the vet perspective, it brings in finances, inconvenience. So it's a very different kettle of fish from having someone come into my room and I can pass them a pill and they can go home and they can crack on their own. And it was sub £100, you know, whoop. But then when you say, well, actually, it's going to be £200 to £300 in first opinion practice, not in your centre, mate. But it's going to be £200 to £300. You're going to have to come back, you know. I'm going to have to ask all my staff to, you know, make a kennel. It's a total different mindset.
Yeah, it's an undertaking.
Yeah. We've got a question here. But before we do the question, there's 37 people watching at the moment. It keeps bouncing up and down to 50. Come on, 37 people, please say hello. It'd be nice to know where you're from, because me and James have only just finished work. So it'd be really lovely to see where the people that are tuning in tonight are from. So we've got this question. My dog is in Librela and Previcox. He still seems in a lot of pain and his leg is lame. He's going back to see the orthopedic surgeon, but I'm thinking if he would be out of pain, maybe better to amputate for a better quality of life. I think without knowing what the other legs are like, what the rest of the body's like, what the actual pathology is, it's very hard to comment. Many times amputation, yes, but what pressure will it put on the rest of the body? Hopefully from listening to James, you realize that you're actually at the beginning of your journey. You have tried Librela and you've tried Previcox. There is still plenty more options out there. So why don't you get back in touch with us after you've spoken to the orthopedic surgeon, and please join Holly's Army, which is our community group. It's completely there for you guys to offload, listen to other people's stories, learn vicariously, get emotional support. So join Holly's Army. But can you add anything, James?
No, I had a very similar conversation with an owner, because her dog, like one of mine actually, suffers from a nerve pain, but the kind of behaviours are directed towards the stifle, so the knee joint in the leg, and so we were talking about whether amputation would be, you know, an option, and it's actually not at all in that case, because the aberrant signaling, the signals of pain are coming from the nerves, which are higher up even than, you know, the thigh. They're coming out from the back. So although the pain perception is down in the knee, the signals causing that perception are up in the back. So you know, in that case, it would have not improved things and potentially made things worse. So, you know, any surgery has the potential to cause a chronic ongoing pain.
And that's something that we don't know anything about. Like in the human literature, post-surgical pain is such a big deal, isn't it?
Very common. Yeah, very common.
And there was, I think there was figures that I read where like up to 40% of knee replacements led to post-operative pain, and 10% of them, of that 40, was like uncontrolled post-operative pain. You're like, ah! So I've always thought to myself, it'd be interesting to do some kind of study on, you know, do we experience this in animals as well. You would assume there's similarities.
Yeah. I think so there's a recent paper which looked at signs of neuropathic pain after amputation in dogs as well. So there probably are dogs that experience kind of chronic neuropathic pain after amputation. So it's definitely not something to be undertaken lightly. And like you say, it depends entirely on what the cause of the pain is and what the rest of the body is like, as to how well the animal can compensate. Because if you lose a limb, you'll always have to compensate somewhere.
Yeah, definitely. So for the lovely lady, I can't remember her name. I think first of all, Andrea, you've got many doors to open yet. Those doors might be working on a more general level of your dog's emotional and cognitive capabilities of dealing with pain. It might be a more generalist mobility across the body, looking at myofascial, etc. But there might also be options to really target the source of pain, such as what James was saying about intra-articular injections. There's also all of the rehabilitative tools that people often overlook. There is laser therapy, acupuncture, extracorporeal shockwave therapy, you name it. There's many other things out there. So don't give it up. Just keep a good conversation with your surgeon. And if your surgeons do have a rehab suite, definitely look into that as well. This is a good one. West Yorkshire, 13-year-old bull terrier with arthritis, still very mobile, just has flare-ups of lameness occasionally, only ever had Rimadyl, interested to see other options for him. There's loads! And if you're interested in learning some of the more common options, there is a whole module about it in our course called CAM Essentials, which is in the CAM Education Centres. That's cameducation.co.uk. CAM Essentials is a 12-module course looking at managing osteoarthritis with a very multimodal approach. You'd be excited. You'd be happy for this dog to come into you because you'd be like, there's loads I could do.
Oh, yeah. Yes, you got lots of options then. I guess that was the other thing about Bryn's case, was the lifestyle thing. So as I said, he seemed to be going off his food, but he ate from a bowl on the ground, and obviously when leaning down, they're putting extra pressure on their front limbs, and actually by raising his bowl, it made it much easier for him to access his food, and he wasn't having to bear all this extra weight going through the front of his shoulder. Even simple changes like that, it's about observing the dog and trying to determine what changes in their posture are going to have.
Yeah, and do you know what? It's probably, even though I have been screaming about it for years, it's still one of the hardest conversations I have running my clinics, is talking about the stuff that people think is fluffy wuffy. And the way that I get around it now, and you're going to like this because it's so wrong, it's right. I say, do you know where Eastbourne is? And they're like, no. I'm like, all right, it's South England. It's where people go to die. And would you believe that every second shop is a mobility store? Because all of these things help people lead a comfortable life. They keep their independent mobility, which keeps you happy, which is all what we want. And they're like, you're mad. It really does work, actually, because they're like, oh yeah, we do it in humans. Why would you not do it in dogs? And people want to reduce the level of medication that they're on. So doing these lifestyle adaptations, be it rugs, be it harnesses, be it raising the bowl, big input. So don't overlook it. Another question for pharmaceutical guy here. My dog has severe arthritis, is on Librela, Carchfem, meloxicam, amantadine, gabapentin. Woohoo! He is mostly comfortable, but his physio hasn't recently identified soft tissue damage. Will any of these drugs specifically help with soft tissue issues? So are there medications that help with myofascial pain?
I mean, in an acute inflammatory state, so a sudden sprain or strain, then a non-steroidal will help with the pain resulting from that inflammation. In more chronic kind of myofascial tensions or the kind of myofascial trigger points and things that we talk about. We haven't looked at it. We haven't got any evidence in dogs, really. There's not huge amounts of evidence in people, but it seems that they respond well to physical therapies in people. So the acupuncture, the laser, the physio manipulations, ischemic compression, those kind of interventions, rather than specifically any drugs. I mean, maybe muscle relaxants could play a role for those. But no, I think, the other drugs certainly don't target soft tissue specifically. They're mostly working on the nervous system to damp down the pain signaling there.
Mm-hmm. That's good. No, that's good. Sorry. I've just got given this amazing light thing and it just turns itself off every now and then. Yeah, it's perfect. I love this message. A vet nurse, hydrotherapist who is really loving her job as a rehab person and 15 years in the field, still learning every day. I so agree. I've gone dark because I've given up with the strobe show. But yeah, I tell you what, it is a field where so much is developing. It's a really exciting time. And I think for me, the stuff that we're still struggling with is communication with the owners, trying to impart this knowledge and this excitement of the treatment options and them to get on board and run with it. I think for me, I still meet lots of people that think that, if it doesn't respond to the non-steroidal, game's over. You're like, so far from the truth. Last question, because we're going to try and stick to time today. Do dogs respond differently to different non-steroidals? If one starts to appear less effective, should another be tried before looking at other type of pain meds? Good question, Stacey.
We think so, but we don't have research to necessarily back that up. But anecdotally, yes, if a dog appears to be deriving less benefit from one non-steroidal and we have a washout period, so usually 5 to 7 days, we say hold off so that we don't end up with toxicity, and then introduce a different non-steroidal, then in a good proportion of cases we can see an improvement again.
And again, that's another difficult conversation, isn't it? You've come to see me, you don't really know me, you've only seen me 15 minutes every 2 or 3 months. I'd like you to try something else because my last thing didn't work. Yeah. And if you do that 2 or 3 times, you really start thinking they're going to stop believing you and that you're kind of like just winging it. But it is the truth. It is worse going from one non-steroidal to another. Sorry, tonight's a disaster. Right. So thank you so much for the question, guys. This is the 3rd week that I've had James come and spend time with us, and I'm so grateful. James is... I love it too. So James is down in the kind of southwest, the Taunton region, and it's really exciting because James actually setting up a specialist chronic pain mobile service. So that means that he actually goes to people's homes and he gets to spend much more time with you and see your animal in their home environment. So if you're in that region and you want to get in touch, I will put his details in the description above and in the thread. Until next time, James is one of the CAM advisors. We have 16 incredible specialist advisors from around the world. But until next time, James, it's been a pleasure as always. Thank you so much for joining us.
Bye-bye, everybody. Take care.